screen, Paul. I can see you. Okay,
Yep.
good. I got that the meeting's being recorded. Very good. So this is me, lanyard dial, lanyard like one of those things around your neck that holds on to a name tag, and dial like dial the telephone. I'm a family physician by training with special interest in the fields of both geriatric and hospice care. Got certified, having completed fellowship training in each of those through UCLA. Currently hold a faculty position still through UCLA as I teach at the residency in Ventura mostly, but also teach physician groups at the various hospitals or in different locations, and do community education around various topics. My obvious specialty interest is in geriatrics, hospice, and palliative care. So today we are talking about, I'm hoping I can go to the next slide, the California Senate Bill 128 that was enacted June 9th of 2016 that goes by the name of the End of Life Options Act. There are a lot of names going around. There's a lot of words people use. I'll try to help you understand that. But for the most part, the official language in the state of California, because of the title of this bill, is the End of Life Options Act. And what is that? The California End of Life Options Act authorizes medical aid in dying. The law allows a mentally capable, terminally ill adult with 6 months or less to live to request aid in dying medication from their doctor for self-administration. Then there's this, if their suffering becomes unbearable, I'm not sure why that language is there, to bring about a peaceful death. The law, which was signed by Governor Jerry Brown in October 2015, will go into effect, did go into effect June 9th, 2016. There's a lot in this paragraph to break apart. Key parts are it authorizes medical aid in dying. So the concept is that an individual can get aid, which is basically support and medications to die from a physician licensed in the state of California. The patient, as it says here, the law allows a mentally capable, terminally ill adult with 6 months or less to live to request aid in dying medicine from their doctor. And that request is for self-administration of that medicine. We've spent years in our country and in many countries deciding who has the right to make decisions about dying. This is steeped in so much history. There are obviously legal issues here. There are medical issues here. There are moral issues here. There are religious issues here. This is a really complex and difficult discussion about the individual's right to make their own choices about taking their own life. We could spend hours discussing from various aspects all of the ramifications that this topic brings up. I'm pretty much going to try to help you stick to the law in California, how it works. Obviously, I have spent my career in dealing with people who are dying and can talk a lot about the various other aspects if there are specific questions people have. But this topic centers around an individual's right to make their decision on when they feel like their life should end. And the law has some clear details to it that we'll go through that try to draw a little bit of a box around what the law is willing to allow. You know, when you think about views in the history of man about death and taking a life, certainly there is in the physician world language of "thou shalt not kill," that death is not something that doctors take lightly, and physicians are struggle a lot with this California law. However, the contrasting view of that, which we also agree with and struggle a lot with, is life is about equality. A quality of someone's life can be defined by an individual of what they believe is quality. The two pictures, obviously, I picked. The first one is a gentleman who's already died, and he's of Indian faith in India, and is being put through a ceremony before he is let loose into the Ganges River. And then the bottom picture is one early picture of Jack Kevorkian, a well-known physician who was an advocate for people having the right to decide their own death. In front of him is one of his various types of devices that he would bring to the home and allow to be hooked up to an individual so that they could take their life. Jack Kevorkian was ahead of this curve of discussion, drove a lot of the discussion, but what he was doing at the time was considered illegal, and he was actually arrested and jailed for his actions. So, like I said, this is a really complicated, multifaceted topic. Healthcare evolves around lots of decisions. We talk a lot of decisions around death issues. We'll spend most of the time today with the End of Life Options Act, which is, in some people's language, assisted suicide. But certainly physicians and healthcare have treaties on suicide itself, how to prevent suicide, how to treat people who are actively suicidal. We in the state still have rights as physicians to remove an individual's right to live freely, incarcerate them, if you will, in a psychiatric hospital to prevent them from taking their own life, from committing suicide. Healthcare and mercy killing has been a bit of a mess in the healthcare world. Mercy killing is when an individual healthcare provider, doctor, nurse, someone has decided that the individual in front of them is suffering so much that we are going to go ahead and take their life. So we administer something that actually takes their life. So it isn't helping with an assisted suicide, it is taking an action directly to take that individual's life. Still all part of the healthcare scene when you get into these discussions. Brain death and organ donation are tied together. We, for years, tried to define what is dying, what does it mean to be dead in America, because we know that we have equipment that can continue heartbeats, that can continue respirations and respiratory effort in people. We can continue kidney function through equipment. So we have a lot of technology that can keep an individual's heart, lung, kidney alive. We don't have any technology that actually keeps the brain alive. So we have defined death as brain death. That allowed us to then pursue a lot more about organ donations, because the vast majority of organ donations are done on individuals who are declared brain dead. And then we have been able to go through a process of harvesting organs and taking them from the brain dead individual and putting them in another individual whose organs are failing. Again, another of the topics in and around end of life decisions in healthcare. Most of you are all very familiar with an idea that has been developed through the years of, I would like to no longer be resuscitated. I'd like to fill out paperwork that says I want to have a do not resuscitate order. I have a living will or a durable power of attorney, or I've completed a post form that describes what I want in terms of my future health care, should I not be able to make those decisions. And part of that is the whole how much resuscitation or other sorts of treatments do you want or not want us to provide you. And medical professionals across the country pretty much are in agreement about the concepts of people having the right to withhold treatments, meaning I don't want to have more cancer chemotherapy and you can't give it to me. I don't want to be on a ventilator and you can't do that. Or an individual who's already been put on a ventilator or who already has a feeding tube in place, wishing to have those artificial means of staying alive withdrawn. All of these topics center around the concepts of our end of life decisions. And each of them have fed into the world of assisted suicide and have lots of obviously background to how they were developed, how people believe them, legal status in most of the United States, where a mercy killing is illegal. Brain death declarations are nationwide. Organ donations are nationwide. The concepts of durable power of attorneys, pretty much nationwide. So I just enter into this conversation reminding you that how complex it is and how we're really looking at one small aspect of this whole issue. And that aspect is the California End of Life Options Act. The best resource online for the California End of Life Options Act is at compassionandchoices.org. Compassion and Choices is a nonprofit organization that came out of the old Hemlock Society, the original organization that was a sponsor and supporter of Kevorkian and his ideas. That Derek Humphrey is a name who was one of the original organizers. And they were advocates for people having the right to make decisions about their end of life and giving them an option whereby they could take their life at the end of their life. They worked in many venues trying to both deal in doctor worlds, in non-healthcare professional worlds, through literature they wrote, through actions they took. And the most successful part of their entire mission was when they created a legal component, and that legal component organization is Compassion and Choices. And what they did was they developed language that they took through legislators in various states to make a plea that legally people ought to have this right. And they chose Oregon as the most sympathetic state in the nation to understanding this argument. And 25 years ago now, Oregon passed their End of Life Options Act law. They then have gone state by state after that to try to get their view of how legally this could be written, what laws could be passed in the states. And to date, they have 10 US states with legal rights to do End of Life Options Act, and California is one of those. Here are the 10 states. I like this diagram because it's quick and easy to look at. The states with currently approved laws about end-of-life options. So if you live in Washington or Montana, Oregon, California, Hawaii, Colorado, New Mexico, Maine, Vermont, or New Jersey. The only thing not on this is the city of Washington, D.C., which is not a separate state, has its own legislature, and it too has passed an assisted suicide End of Life Options Act legal status. The remainder of the states have either been targeted by Compassion and Care to develop and help, or have decided they want nothing to do with this and have passed laws absolutely in the other direction, saying it is illegal to do this kind of care in those states. So I have a subsequent slide that explains that. So here are the red 10 United States, that each state that allows, that to happen. Again, the 10 being those marked in red. The blue, where there are bans still in effect, that legislation hasn't been enacted either way. And the greens, where there are new laws that are opposed to physician-assisted suicide. So the green states on here have enacted laws to counteract any compassion and care activity in their states. The blues still have not made decisions one way or the other. And so that's the status right now of the idea of end-of-life options. The title here is Assisted Suicide and its legality. So we're in California. We have passed in a End of Life Options Act in 2016, and we'll spend the remainder of this talk discussing what that law is, how it works, how people access it. What I can tell you is that every state that has passed this law, all 10 of the red states, patterned their law with the help of Compassion and Care. And so the laws are virtually identical in every state. Now, obviously, the legislatures could have made little tweaks. And in fact, California's made a tweak, and I'll show you that tweak. Oregon is on the brink of making a tweak this year to alter their law. I'll show you what that is. And so, although the laws are written by the same group of people initially, the legislators of each state have made subtle differences in each of them. So what I'll tell you today is what I know is in effect in California, but you could likely find very, very similar language in the other states. So here's what the law says. First, it defines a qualification of the patient. Is this patient that is in front of you qualified to receive End of Life Options Act medications? Then the requirement of the physician to inform the patient about their diagnosis, their prognosis, and what options they have. The patient then requests that they go through the process and they complete a form that relates to that request. Then they are referred from that primary physician who's made the determination with the patient that they're qualified, and they have given them the diagnosis and prognosis. They've helped them fill out the form they needed to fill out by showing them what details need to be on the form. And then they've referred them to a consulting physician who agrees with the initial physician as to the patient qualifications. Then the patient is returned back to the original physician for another counseling session. And then there's a final agreement and a prescription is written. And the patient then takes his prescription, his or her prescription, and the physician completes more forms documenting that's what happened. I'm going to go through each of these. This is the framework of how the law is written. The law is written to protect everybody. The law's attempt is to protect the doctor from being sued, the patient from being sued, the family from being sued. It's to protect the patient's rights to be able to get health care needs met and insurance needs met. It's to protect the pharmacist. It's to protect the manufacturer of the prescription medicines. So the attempt by Compassion and Care was to draft laws so that no one who participated in this would be treated like Kevorkian and arrested. No one who was treated like this would be at risk of losing insurances or having some adverse type effect happen. So the law has lots of details in it. There is documents and reports done at the very end. So is the patient qualified and the doctor informing them about their diagnosis and prognosis options? What makes a patient qualified and well-informed? One, they must be a terminally ill adult, 18 years or older. This law does not speak to people under the age of 18. And terminally ill is defined in the law as 6 months or less prognosis. Like I mentioned earlier, I've been a hospice physician for close to 35 years, 37 years. And the definition of terminally ill is vague in America. It is not well spelled out. There is no clear, this is what makes someone terminally ill. It is a very vague terminology left up to the physician or nurse practitioner to make a decision that they believe this person is terminally ill and has a prognosis of 6 months or less. They, as I mentioned, and we'll show you again, once this doctor, nurse practitioner has decided that the person is terminally ill, they have to have a consulting physician agree with that. So there is a second, if you will, check on that. The language in the hospice world is similar to the language in this law, that would the physician believe in all with reasonable expectation that this person will likely die in 6 months or less. It does not list out diagnoses. It doesn't list out any more specifics than that. So the terminally ill piece of it is not very crystal clear spelled out. The patient has to be a resident of the state of California. The law puts that burden of that determination upon the person who's going to write the prescription. So it is the physician or nurse practitioner to determine that this person is a resident in California by a driver's license, voting registration, land ownership, documentation, they pay state taxes. I'll tell you, the vast majority of physicians spend very little time worrying about the person being a resident of California. This year in Oregon, the same language existed in the Oregon law, that the person must be a resident in the state of Oregon. But this year, it is highly likely Oregon's going to take that out of their law. They've had enough years of dealing with this. Again, they've had it for 25 years in place, and they believe that the residency requirement has no role any longer, and they're going to remove it. Now, historically, there was a resident of California when it was not legal in California who moved to Oregon to establish residency in Oregon to get medicine. And that was a big case that was cited by the Compassion and Care Organization to the California legislators in order to get this passed in the state of California. So the residency requirement seemed to be a huge part of this law initially. Oregon will be the first state that removes that should the legislators decide this year to remove that. California still has that in existence. The law still stands that you have to be a resident of the state of California to be eligible. So are you qualified? 1, are you terminally ill? 2, are you a resident of the state of California? 3, are you mentally competent to make medical decisions? Another very vague statement in the law, another statement that is totally dependent upon the decision of that individual physician who's doing the evaluation to both decide if the patient's terminally ill and mentally competent. The second physician, who is the consultant, has to agree that the patient is terminally ill and mentally competent. So those are the 2 key phrases to the patient's condition for them to qualify for the End of Life Options Act. They have to be acting voluntarily, and they have to have witnesses who are there to see that they are acting voluntarily when they have this request. The state does require 2 witnesses to document that they believe this patient is requesting this of their own volition. And the patient has to be judged to be capable of administering this medicine or medicines themselves. This is not medicines that can be administered by somebody else to the patient. This is part of the whole worry about mercy killing and who's made the decision and who is giving the person the medicine. The patient themselves must make the decision, and they themselves must be capable of administering the medicine. So you document that the patient's fully informed of what the diagnosis that makes them terminally ill, that you've discussed with them what actions the drugs are going to have, and clearly document on physician documentation forms that there's no obligation that they take this medicine. They are doing this totally voluntarily. There's a whole checklist that the state provides to physicians who are doing this, and that checklist is completed by the doctor prior to any prescriptions being given. Let's see if I can go back here. The patient who requests these medicines has to be made solely and directly by the patient with the terminal disease. So this means that no one else can ask a doctor for this medicine. It can't be asked for by a power of attorney. a healthcare directive, a conservator, a loved one, any kind of surrogate, any other legally recognized healthcare decision maker? No. The only person who can ask and complete the forms to get this medicine is the person who's going to take the medicine. Again, built in to create protection so that no one is accused of forcing somebody or taking someone's life when they didn't want it. Original language in the bill was that there had to be 2 different requests for the medicine 15 days apart. Last year, the California legislators altered that language. This was the revision I mentioned that happened in the state of California to this original bill, and said, you know what, it doesn't need to be 15 days, it could be 48 hours. So they're trying to make this more available to people so that they don't have to wait longer with their terminal illness. So they moved the 2 oral requests to 48 hours apart. So you make a request of your doctor, you complete paperwork, then 48 hours later, you can verify, yes, I still want that, and complete paperwork so that it's clear you've had time to think about it, and you continue to want this. There is 1 written request, and that's what has to have 2 witnesses. The attending physician, consulting physician can't be one of those witnesses. The witnesses cannot be the person who's going to write the prescription, nor the second person. Again, protections for individuals. In fact, they don't necessarily want both witnesses to be related to the person. And they don't want both witnesses to be involved in operating or owning a healthcare facility where that person happens to be living. So it could be one person who's related and one person who's working at a facility where the person's living. Can't be, both of them can't be the same. If there's a language issue, there's a document that has to be filled out by an interpreter that's used so that the consent and completion of the written request has a very clear interpreter language in it. And there's an interpreter criterion form of their competency to be an interpreter for this. Again, you can feel the concern over making sure that this is done right. That's part of the law, the language issues. So we've done is the patient qualified, the patient's been informed, the patient has requested it themselves twice in 48 hours, they've completed paperwork if they need to have an interpreter, and now comes a referral to a consulting physician. That consulting physician means another physician independent from the first physician, and they don't define independence. So if 2 doctors are working in the same group, for example, Kaiser Healthcare, could the initial doctor and the second doctor both work for Kaiser Healthcare? Yeah, that's fine, as long as they aren't partners in the same office. Could one be a UCLA faculty member and the other a UCLA faculty member? Sure, as long as they're both not in the same office. So an independent physician who is qualified by specialty and experience to make a professional diagnosis and prognosis about the individual's terminal disease and mental status. And there's a consulting physician form that gets completed. The patient's counseled. There's a final document that's filled out by the doctor, and then the doctor can write the prescription. The counseling that's recommended is that the physician have another person present. That the patient have another person present when they adjust the medicine. The physician counseling is to make sure that the individual, when they take it, is safe. And so the recommendation is that you have another person present when you ingest the medicine. This isn't a requirement of the law. You don't have to. This is the counseling piece that the physician is being recommended to do. That they not ingest the medicine in a public place, that there is involvement of the next of kin, so that people are aware of what's happening. Again, none of this is in the law. This is what physicians have said they believe is the right thing to do in discussing with the patient. Hospice programs, there's a general sense that people should be part of a hospice program when they do this, so that they have the support that hospice brings into this environment. That when they get the medicine, they should keep it in a safe and secure location. That this is in the law, that the physician must counsel the patient that they may withdraw or rescind the request even after they've gotten the medicine. They don't need to take it, and offer the individual an opportunity to withdraw or rescind their request for the medicine. They want to give every opportunity to the patient to say, this is what I want to do. I understand my rights. And the attending physician must verify before writing the prescription, again, that the patient is making an informed decision about what they're doing. When you write the prescription, there is a attending form. There was a patient final attestation form filled out by the patient 48 hours prior to they took the medicine. That too was struck out of the law 2 years ago when the rewrite was done, along with the changing from 15 days between oral requests to 48 hours, and elimination of the final patient filled out attestation form. The physician still has to do that. And then the physician writes the prescription. Now you get into some of the nitty details of this prescriptions and the medicines and how things work. So when you write a prescription for medicines in the state of California, there is direct contact between the doctor and the pharmacist that such a prescription is being written. And so typically the doctor will phone call the pharmacy that they know the patient's going to be using. However, because prescriptions these days can be mailed in, because prescriptions can be done on the computer, this direct contact is not specifically spelled out. The prescription itself can be taken to the pharmacy any way it can get there. It can be electronically done. It could be in the mail from the doctor to the pharmacy. It could be from the patient to an online pharmacy. Once the prescription's written, it's kind of out there. It doesn't have an absolute requirement of what you do and how you get it. Medication could be dispensed by the doctor if the doctor's authorized to do that. Now, doctors are not authorized to dispense medicines usually. It's rare for doctors to have a pharmacy license to dispense medicines, particularly not the medicines that are involved in this treatment plan. Doctors can have sample medicines in their office that they can give patients to try, but none of these medicines are involved in that. So it is unusual in the state of California to have a physician have medicine sufficiently in their office and to have pharmacy prescription authority from their offices. This is another interesting thing with all the safeguards that are there, that the pharmacy can actually hand the package of medicines to anybody. It doesn't have to be directly to the patient. It can be any authorized individual. It can be mailed to the patient. And so there's a little looseness here in my mind of once you've gone through all this kind of documentation and tight-knit things to figure out that the patient themselves does not have to pick up the medicine, that it can be mailed to them, or somebody else could pick it up. So what medicines? Well, the first thing is to be sure that patients are given pre-medicines, medicines that include some type of antiemetic. You do not want people throwing up the medicines that they're attempting to take their life. So when you are prescribing the medicines to have someone self-administer to end their life, you pre-medicate them with some type of antiemetic, and these are the two usual drugs people use. You also recommend that the patient has had no fatty foods, again, trying to decrease the risk they could throw up. Their medicines that you're getting to do this are powdered, and they're mixed into a liquid slurry. They're not dissolved in liquid because they don't dissolve totally. They create a slushy like liquid, and you use a small amount of water. You don't use a full cup of water because you don't want to have to drink a full cup down. So somewhere like a half a cup of water. It is true that the medicines that are powdered and mixed into a slurry can be a bit bitter. And so it's okay to use other than just water, or you could mix them into another thing like applesauce or puddings, so that the person can take them. They should consume this relatively quickly, meaning this isn't a sip over the next hour kind of drug. This is a consume it in a few minutes, get all of this into you, mix the powder up in the water or the applesauce or the pudding, and eat that whole thing in a minute or two. And certainly after you've taken that in, if you want to have a sip of something else, feel free to do that, so that you take the taste out of your mouth, so that you're assured that you rinse the mouth and most of the medicine has been swallowed. And death then usually happens within around 30 minutes. And it happens because your respiratory system isn't supported. The medicines cease your body's ability to breathe. And your consciousness is altered, and you die in around 30 minutes after taking the medicine. This is a table from Oregon. The Oregon legislature, as did every legislature when they created this, has the requirement to track and keep statistics over the use of this law. And this table was written in their last publication, dated January 2023, and it shows the medicines that have been used over the last 10 years. The original medicines that were used were pentobarbital and secobarbital. These were used back when this law was created, and continue to be used up until around 2013 to 15. And that's because manufacturers of these two medicines decided that they would start to wean this medicine and make it unavailable. Pentobarbital first became unavailable, then secobarbital later on. As you can see, its use stopped around 2019. People then tried other medicines. They tried phenobarbital alone. You can see that's the orange line there. And it was tried for several years. people tried 3 combinations of medicines. DDMP was the first, and I'll show you what that is, and you can see it's not being used anymore. That was replaced by an attempt to use DDMA, which became the prominent drug early in 2000, until someone said DDMA is better if you add pH, and that took away the use of DDMA, so that now most prescriptions are DDMA pH. The laws don't tell you what prescriptions to use. There is no national standard prescription. This is all the experience that is coming from the communication amongst the physicians involved in their states. So in California, people are following what they've learned from Oregon. So the vast majority of prescriptions in California today are the DDMA pH. Okay, secobarbital and pentobarbital unavailable. DDMP is diazepam, which is Valium, digoxin, which is a cardiac medicine, morphine, and propranolol. DDMA, which took over from the DDMP, is diazepam, Valium, digoxin, morphine, and instead of propranolol, amitriptyline. Amitriptyline historically is a potent antidepressant, but it has terribly toxic heart side effects. And so it's almost not used anymore in the treatment of people with depression. But it has found a role in the end-of-life drug mixture that includes Valium, digoxin, morphine, and amitriptyline. And as I mentioned, the last couple years, it's found that if you add phenobarbital to that, it's more effective. So the current use is DDMA pH, Valium, diazepam, digoxin, morphine, amitriptyline, and phenobarbital. And obviously there are the dosages of how much of each of those is part of the mixed powdered substance that gets put into the liquid people consume. This is also from Oregon, duration between ingestion and death. In the Death with Dignity deaths between 2001 and 2022, down the left-hand side are the drugs: secobarbital, DDMA, pentobarbital, DDMA PH, DDMP 1 and 2 were 2 different strengths of the propranolol that was in it. The phenobarbital alone time. And what's interesting is the second column is total number of people who got that medicine, but we don't know how long some of them took to die after they took it. The statistics are on the people where we know how long it took from the time they took the medicine till the time they died. So all the statistics on the right 3 columns relate to the cases where we know this is the medicine they used, this was the dosage they used, and this is how long it took them to die. So 390 people taking secobarbital alone, 294 died in less than an hour. 1 to 6 hours was 69, more than 6 hours was 27. That's how you read this chart. So what you'll see is the reason DDMA was dropped in favor of the phenobarbital, in that more people died sooner, with not many more lasting longer. So that's how the statistics are gathered here, and the conversation about what are the best drugs. And you can see there was a time frame, if you remember on the previous slides, where phenobarb was used alone, and you go down to the phenobarb column on the left, the drug percentage phenobarbital go across, and you can see it took too long for people to die taking phenobarb alone. Pentobarbital and secobarbital worked very well. They're off the market, no longer available. So now you're looking at DDMA, DDMA-PH, DDMP, and can see the statistics are the best for DDMA-PH right now. So that's how we got there. The attending physician is required to submit any follow-up documents that they have after the person's died, and that submission has to be within 30 days after the death, and you submit it all to the California Department of Public Health. Rights of physician, pharmacists, and institutions. Doctors have the right in the state of California to say, I don't want to do this. And you cannot be persecuted. You can't have a lawsuit against you saying you do not want to participate. Pharmacists can say, I don't want to fill those prescriptions. Institutions can say, we will not serve those patients. So as examples, many of the religiously affiliated hospitals and hospital systems or universities have said, we're not participating in this. And in fact, the doctors we hire cannot participate in this. So as I mentioned at the very beginning, there's a lot of issues involved in this from a lot of different perspectives. And certainly institutions have the right with the law to say they won't participate. And if they employ the pharmacy or the doctor, they can make that decision for the pharmacy or the doctor. People are also protected from lawsuits or censures if they do participate. And they specifically say, unless you are participating and there's an employer who says you can't, then you're not protected. The employer has the right to tell you, if they employ you, whether or not you can participate in this. So the classic here is a doctor working for a religiously based health system, and the religiously based health system has said our doctors will not prescribe these medicines. And you have a doctor who makes a decision that they're going to prescribe these medicines. The law does not protect that doctor. The employer can sue them. You can have a felony prosecution for certain aspects of this law. This is written into the law. If you're forging or altering a request or destroying the forms that the patient filled out to withdraw from this, you could be subject to a felony prosecution for forcing that person to take that medicine. If you are coercing any individual to participate in this and take the medicine, this is individual meaning patient, is being forced to take the medicine, you are potentially liable for felony. If you assist the patient with taking this medicine, you are liable for a felony. This is a very interesting one. What does it mean when it says assisting? And that's not very clear. You can see what they're trying to do. They do not want people forcing this medicine into people. So they're doing their best to try to write a law that does that. There are also rights for the patient. This death is not considered a suicide. So the death certificate filled out after someone uses this medicine lists the death as whatever their terminal diagnosis was. It does not mention that they used end-of-life option medicines. Health insurance cannot discriminate against this person, and life insurance has to be paid out. Just because you took the medicine does not mean you committed suicide, and life insurance has to pay out. The death is listed as due to your terminal diagnosis, and health insurance has to pay for things that are needed, and life insurance has to pay out. There's records that the doctor has to keep on everything they've done, including the consulting physician. All those records have to be monitored by the state. Documents have to be there that report exactly what happened. If there was a sense of any kind of mental incapability of the person, then the doctor was required to get a mental health specialist assessment to do that. You have to have documented that you offered the patient that they could withdraw the request for this medicine at any time, and the note that all requirements have been met before you write the end of dying drugs. And then the doctor has to complete a final form. Here's Oregon, and here's the history of what's happened in Oregon since 1998 and the beginning of this law. The orange line is how many deaths have happened because people took the medicines, and the blue line is how many prescriptions were written in any given year. From the origination of this in 1997 through 2022, 3,712 prescriptions have been written and 2,454 people have died using them. One of the things that's consistent in all the states is that there are people getting prescriptions and not using them, or getting prescriptions this year to use them next year, so that the reports are done each year. And so it looks as if there are more prescriptions written than people who died. And so that's fairly characteristic. You can see that the initial parts of this up until around 2012 or 14 range, sort of flat, and it's increasing some as this is becoming more understood, more accepted by people, and people are getting more comfortable with the concept of end-of-life options. Here's California. Since 2016, when the law went into effect, you can see the year by year, and it also goes along with the Oregon piece, that there was some flattening at the beginning and then a rise in the last years. California has a lot more people, so when you look at the shorter time frame, there are more prescriptions and more people who've used them and died from them. So those are the California numbers. Again, this is all from the state of California's Department of Public Health reports. They have a report written every year. This is the concept I just said. If you look at the single year of 2022 in California, 1,270 people have prescriptions written. 803 of them, the green in the middle there, actually took them medicine in 22 and died. 294, we don't know what happened yet. And 173 died, but it wasn't because they took the medicines. They had a terminal disease and they died from that disease. However, that year, there were 853 people who took drugs and died, and 50 of them had their drugs prescribed in the years before. So this is the complexity of gathering the data, is when was the prescription written? When did they take it? Do we know if they took it or not? And they are dying from their terminal disease. There are some real problems here that we've talked some about. I wanted to share a few more. Finding a doctor who's willing to participate in this isn't easy. Many physicians don't believe about this is the right thing to do. They have the right to not participate. So finding physicians in the area that are willing to participate isn't easy. I know a dozen or so doctors in Ventura County who would write a prescription, but it has to be for a patient they've followed over their career. Patients they've cared for. They do not want to be known as a doctor willing to see somebody else's patients. They're willing to do this if it's a patient that they know their family. As I mentioned, medical organizations can have a corporate policy that prohibits these medicines in their facilities and that kind of thing, and physicians working under those facilities are prohibited from prescribing. That exists in Ventura County. We have medical corporations, medical facilities that refuse to allow this to be done under their watch and by their doctors. The medicines that we're using doesn't have any standard. You can see kind of what people are thinking these days. And obviously it has to be a terminally ill, mentally competent person, and anybody with dementia is not mentally competent to make this decision. So that's the end of my presentation. I am going to unshare my screen and